Sam, thank you very much for that introduction. Can you hear me?
Yes, I can.
Thank you. Hello, everyone. Welcome to this presentation on aortic acceleration as a non-invasive alternative to DPDT max to quantify left ventricular contractility in small animals. And I'll briefly also touch upon assessment of cardiac function using other blood flow velocity measurements as well. I will briefly talk about why and how of Doppler methods and lead into application studies. Essentially, the acceleration will be the main focus of this presentation. And then I'll briefly discuss other cardiovascular measurements. So we all know that rodents, specifically mice, are the animals of choice in basic research because of ease of genetic, surgical, and pharmacological manipulations. And all these alter the cardiovascular system. We need, for this to study these alterations, we need to phenotype these animals. But most cardiovascular measurements and parameters are functions of time. So we need waveforms. And the challenge is to be non-invasive so that we can serially follow these animals throughout their lifespan. So briefly talking about pulse Doppler ultrasound, what are the advantages? It's non-invasive. And so that allows us to do longitudinal studies. The signal acquisition times are short. It can be, these signals can be measured at various arterial sites. And we can do this by achieving very small angles. So if you look at the probe here, this is very small compared with echocardiography probes. And the key thing in using pulse Doppler is knowledge of anatomy. So you need to know where the vessels are with respect to the cutaneous from the surface of the skin. And also it helps to know the shape and timing of waveforms. That way you can recognize if you are at the right site or not. So I just want to remind you, this is not an echocardiography system. And we're going to get into the methodology. And here we have how we measure the signal. So you take a Doppler probe, place it on the skin with some coupling gel. Of course, the skin has to be shaved for easy access to that location. And then you aim the beam into the vessel of choice. And then there is a control that you can use to place the sample volume in the vessel and you get the signal. So it's sending out a echo pulse. It's sending out a pulse, transmits a pulse, you get the echo back, you capture it within this window before the next pulse is sent out. And the timing between these pulses is what determines the frequency. And so you can get the signal, and it is velocity can be calculated using this formula. Very simply, it's a function of angle as well. So that's why I was mentioning the angle earlier. Moving on, why blood flow velocity? And we have to understand this, we have to look simply at the scaling. So the table here shows the general allometric relationship between the cardiovascular parameters and the body weight of the animal. But just getting to the bottom of it, looking at these three parameters, you see the velocity, pressure, and pulse wave velocity are independent of body weight. And this becomes useful in comparing data across species and makes it easy to interpret translational studies. So shown here is a simple setup of the pulse Doppler system. Here is the ECG board onto which the mouse will be taped. The ECG can be observed on this tablet as well as sent to the Doppler program. Here is the Doppler system, and where you use the probe, and then and this is the remote control where you control the depth at which you are listening to the echo, and the signal will be displayed on the screen. Here is a setup, experimental setup for doing that. You have isoflurane cone, animal is taped, and you got your probe, and you can adjust your signal depth to where you're listening to, and you get a signal on the screen. So with this configuration, I wanted to just touch upon the importance of this. The board here has a warming zone to counter the loss of core temperature in anesthetized mice or rats, while having the ability to monitor ECG and respiration. So it can be used while performing non-invasive or invasive measurements. And it is very important during surgeries because maintaining a core body temperature during surgeries will make the recovery that much better. With that brief introduction, I would like to now continue into the application. We will look at the cardiac systolic function, which is the main focus today. So how do we measure this? Here, like I mentioned earlier, you take the probe, place it under the xiphoid process, and aim it towards the right ear of the mouse, sort of to the right side of the mouse. And if you adjust the range to place the sample volume in the at the aortic root, you should get a nice signal. And from the signal, what do we do? Just put the markers to get the timing and the velocities, and then calculate a whole series of parameters. And these parameters are nothing new that we have created. They are all clinically, all these parameters are measured, and we used the echo manual to get these parameters. So over the years, we have done many studies, and here is a summary of data from all those studies. And we're mainly looking at aortic outflow in this particular slide. So if you look at young, very close to 100 centimeters per second, which is same thing that we see in people as well. With aging, you see that the aortic flow goes down. So there's a systolic function deterioration or lowering of diminished systolic function, if you will. We did a study also to restrict, put these old mice on restricted diet, but that didn't seem to improve their systolic function. This is the data from a young hyperthyroid mouse. So you can see, obviously, the systolic function is enhanced. This one is a CIS2 mouse, which has got increased IGF. And this is a 1-year-old mouse, so you could see that it is maintained its systolic function even at 1 year. This is a little dwarf mice. The interesting thing about the dwarf mice is they live longer than their wild type counterparts. They're smaller in weight, but they seem to, and they have diminished systolic function or aortic outflow, even at very young age, but this is maintained throughout their lifespan. Similarly, the case of a naked mole rat, this one lives about 30 years, and it's got diminished systolic function at a young age, which is considered to be around 2 years, and maintains that throughout its lifespan. In contrast, you can see in ApoE mice, we have plaque buildup and and we see that its demand for oxygen is higher. We have also shown that their hemotic rates are lower, so perhaps the demand makes the blood flow velocity go higher. And this is in mice that have been treated with angiotensin for 6 weeks, and we get pretty high velocities. Now, moving on, I wanted to quickly show some studies that of cardiac systolic function, aortic velocity examples. So this is the data from murine myocarditis caused by encephalomyocarditis virus. And this group of animals were treated with apretin, and you can see that restores the systolic function back to normal compared to their sham counterparts. Here is an example of the using of a missense mutation in the KL3 gene. And this is known to cause very high peak aortic velocity. So this study was interesting that they used this this trait of high flow velocity to identify the mutants. And so the normals have, the wild type have normal velocities, and these have almost twice that. In the third example here, this shows ICAR-dependent AMPK activation, and this prevents adverse reverse modeling after myocardial infarction. So you can see that there is an increase in aortic flow velocity compared to saline injected. All the mice have undergone myocardial infarction. So treating with saline and treating with ICAR shows improvement after 4 weeks. So we'll jump to the main part of our topic here, which is cardiac contractility. And you all may know how this is done. Most of you may know that. And you have a catheter that you introduce from the right carotid artery that goes into the ascending aorta and then eventually into the left ventricle. And you can get this nice ventricular signal. And you take the derivative of this left ventricular pressure signal, you get the positive dPdt, and you can measure the negative dPdt. Unfortunately, this is invasive, and most of the time the animals are terminated right at the end of the experiment. So, and looking at invasive versus non-invasive measurements. So we already said it's a terminal study, and it's an acute study. That means anything that you have to do at that point, whether it's interventions or just getting baselines, that is it, and that study ends there. But one of the things we have noticed, because when you are doing LV pressure measurements, you rarely measure aortic outflow. What we noticed is that when there's no catheter, we have nice 103 centimeters in this case, for this particular mouse, no catheter. And once you put the catheter in the ascending aorta, the velocity go up, of course, because the catheter is now occupying space in the aortic left ventricular outflow tract as well. And now when you push that catheter across the valves, that the velocity goes up even higher. And so, and then not only that, here we don't see any regurgitation because it's not across the valves. Valves are closing perfectly. But now here, the valves are not closing perfectly. There's some kind of regurgitation going on throughout the diastolic period. So that is another issue. Then not only that, we are cannulating the carotid artery, that means we are closing it off, it's tied off. then we are straightening the ascending aorta with our catheter, although catheter looks very flexible, but it's kind of straightens the aorta. And it also kind of pushes the heart to align with the catheter rather than the other way. And this becomes a problem in atherosclerosis or other mouse models with stiffer arteries. Atherosclerosis with plaques and other things, sometimes it's harder to cannulate, put a catheter that goes across the valves. So with all these issues, I think a non-invasive method is warranted. So this has some precedent. I mean, it's not the first time we are doing this. It's probably the first time we're doing this in mice. Lambert et al., is and his group. They have looked over the years at all the measurement types for getting left ventricular contractility, and they did a study where they used all the methodologies for their application, and they ranked these methodologies in terms of their sensitivity and specificity. So here you can see the top 7 sensitive indices. All of these require invasively measured LV pressure. So we are not going to go there. So we'll skip those. The immediate next ones are the non-invasive ones, and starting with mean acceleration and peak acceleration. And then followed by the DPDT max, which is, according to them, less sensitive than the non-invasive indices. So based on this study, which was very encouraging to us, we went ahead and not only that, we also looked at the study in dogs, and where they showed a very good correlation between non-invasive and invasive methods in patients as well, and even in sheep. So with all this in mind, we decided that we wanted to do a study in mice to validate, because people have used the mean aortic acceleration or accelerations to define based on studies from other animals. But we wanted to show that it also works in mice, because now the catheter size with respect to the heart is much, the ratio is much larger, if you will, compared to when you take a small catheter and put into larger animal hearts. So here we put a catheter, like I said, and then use the aortic outflow. That's what you're seeing here. And you export these, extract the waveforms and then export them and to the derivatives. So here you have, so you can see these are all simultaneously obtained with whatever physiological delay there is. And so you can see they clearly follow each other. And here is how we measured it. So beta P prime, that's what is DPDT. And here is V prime. This is the peak aortic velocity. And we calculated mean velocity using this, the peak divided by the time it takes to reach the peak. Moving on, and using this data, we compared peak acceleration versus DPDT and mean acceleration versus DPDT. And we found that they had a very high correlation after regression analysis, found that they were both highly correlated with the invasive pressure measurement. And one of the things that we also thought was that we have non-invasive methods like echocardiography. So why not use that to get, we already have this, we measure this to get our contractility measurements using dimensions and things like that. So one of the issues would be that if you were to do echocardiography measurements, you will be limited to fewer usages. There are some institutions where people have to wait in queue to get their measurements done. Um, these measurements take longer time. And as you can see, you have to place a lot of gel on the animal. You're kind of changing the physiology in addition to, cooling the animal and things like that. Of course, even if you use warm gel, there's still sometimes you have those effects in place. So what we did was to put some of this the debate to rest, if you will. We used the echo probe. Simultaneously, we put a Doppler probe, and you can see that we tried to get it as low as possible, um, given the constraints of the board and things with the echo. And you can see the roughly these angles are approximate. So that's what we estimated. And we did a comparative study. So these are done simultaneously. There's no interference of the echo with the Doppler probe or the Doppler probe interfering the echo. There's some speckle noise, but that doesn't seem to affect the velocities or anything like that. And so you can see very quickly the comparison here. You've got a 90 centimeters per second with the Doppler probe. We didn't do any angle correction, although we estimated to be 25. And with the echocardiograph, we didn't put any angle correction. So these are the numbers that came out as we did the analysis. And we forced a 45-degree angle correction, and you could see that it gets to 80 to pretty close to that. We didn't exactly try to match that, but we get the point that you have to use angle correction in echocardiography. Now, this angle correction will not matter if you're doing an acute study with echocardiography using interventions and looking at before and after response of the contractility. But if you're doing serial studies and you're doing one measurement today, one measurement maybe 1 month away, and then 6 months later, then you have to make sure you place this probe in approximately the same location, because any change in the angle at higher angles is going to have larger effect than any change in the smaller angles. So we should put up this slide and did this study just to show that whatever you're measuring with echocardiography, if you're looking at contractility, whether it's before or post, you see very similar measurements, whether you do it with Doppler or echocardiography. So now, if you want to do dimensions, echocardiography is the way to go. There's no other way around it. But if you just want to get a quick serial measurements, you can use the Doppler system, which is within few minutes, you can get your measurements and you're done. So with that, I wanted to show some of the acceleration examples that people have used in the past, even before we did this evaluation study. Here is one with done by, I think this is Vincelet et al., this group, where they showed that there was a reduced cardiac reserve in ApoE mice as shown in the peak aortic velocities compared to the wild type, and also a dose-dependent response to dobutamine. And you can see that at 3 microgram per gram of dose, the ApoEs didn't respond as well as the wild type. And then going to from 3 to 10 didn't matter because it was already saturated in the wild type, whereas we had to, this group had to use a higher dosage to get to the maximal response of aortic acceleration. Moving on, this is an example where showing the restoration of peak aortic velocity and mean acceleration to normal levels in null mice at 8 months of age. This is again another example. This is our group having done this with the ICAR. They also showed that the mean acceleration is also improved with the ICAR injections. And moving on, this is another study that also showed that you can use peak aortic velocity or mean acceleration to determine cardiac systolic function. And this is in tact banding, and you all would know that you cannot, or it's not easy to put a catheter in a, putting a catheter in the animals that have undergone TAC means that you're shutting off the only vessel or the main vessel that is absorbing all that extra pressure load. So this is a good way of doing it non-invasively and still getting the contractility type of function in these animals. So with that, I would like to hand over to Sam for a quick poll. Sam?
Thank you, Anil. Give you a chance to catch your breath and perhaps get a drink of water. Yes, thank you for that presentation so far, Dr. Reddy. Based on the information, we would like to know if you perhaps are interested in a virtual demo of the Doppler Flow Velocity system as presented by Dr. Reddy. You know, it's difficult sometimes to attend labs in person, and we hope to one day soon, but in the meantime, we are hosting virtual demos. So if you're interested, the options are yes, no, perhaps not right now, but in the future. Or if you would like just more information, we can definitely send you more information. And thank you again for participating in today's presentation. We also would like to encourage everyone to continue to ask questions. We will get to them at the end of the presentation today after Anil, Dr. Reddy finishes his presentation. All right, thank you everyone for participating. I'd like to bring back Dr. Reddy to finish his presentation. Dr. Reddy?
Yes.
Thank you.
I'm here once. All right. So the second part, the presentation, I wanted to make sure it's sort of complete, not left hanging. So I'm going to present a few more measurements that we have done. I'll try to go quickly over these, but so that to get for the sake of completeness of cardiovascular measurements. So here is again, we talked about systolic function. Now we're going to briefly discuss diastolic function. So same probe oriented towards the left ear or left side of the mouse. And then you're aiming towards the mitral valve. Again, you have to use the remote range to get, to the appropriate depth, and you can get a nice signal. And with that also, with that signal, you get all kinds of timing information as well as peak velocities. And all these are used in clinical systems, like I mentioned. And from these markers, we can get a whole bunch of parameters. But in the interest of time, I'll be looking mainly, most of the time, we are interested in EA ratio, which is sort of a diastolic function. See how this ratio tells us how well the heart is relaxing. And so we will just look at this part of the waveform. And you can see in the young mice, they have a nice relaxation. If you go to old mice, the E and A ratio starts to decrease over. One of the things, the study that I discussed in the when I was showing aortic data is that in calorie restricted old mice, the systolic function did not improve, but we saw a huge improvement in diastolic function with calorie restricted in calorie restricted mice. Again, hyperthyroid mice, same group. Uh, we saw enhanced systolic function, so we also have enhanced diastolic function. These are young hyperthyroid. We did not measure when they are older. Perhaps these functions deteriorate in ways that, at least right now, we don't know. We also looked at the 1-year-old CIS2 mice. The 1-year-old CIS2 mice systolic function was maintained, but now its diastolic function is deteriorated, perhaps because of the systolic function being maintained. The heart may have hypertrophied and the relaxation might have suffered from that. In the little dwarf mice, again, it's the same story. They have diminished E and A ratio. They have diminished systolic function. Here they have diminished diastolic function, but they seem to maintain that at the same levels throughout their lifespan. And the same thing with the naked mole rats. And so see that non-invasively, you can follow them sequentially and serially throughout their lifespan and characterize these animals. We can get signals from several other arterial sites. We already talked about ascending aorta, but we can also get from aortic arch, from descending aorta, from coronaries, left and right carotid arteries, renals may be a little bit difficult to get, but we can measure those as well. In the abdominal aorta, whether it's here or here before the renals, we can get those signals. And we can, I didn't show the femorals and other locations, but you get the point that non-invasively we can get from many locations as long as you can identify the vessel and the shape of the vein. So quick example of how we use coronaries. Of course, coronary reserve is one of the things that we are interested. Coronary, if you get a coronary flow velocity signal, it doesn't mean anything. We need to know what is its capacity, how much flow it can increase. Fortunately for us, we don't have to inject adenosine. Isoflurane is a good coronary vasodilator. And so when we increase isoflurane to 2.5%, we see a huge increase in its peak, the velocity. And this is the diastolic part. That's when coronaries get perfused. Systolic part, there's hardly any perfusion. From 2.5, when we drop down to 1.0, this flow velocity drops down significantly, coming to around 25 to 30 centimeters. Sometimes we even have seen 20 centimeters per second of velocity. We use the ratio and calculate a coronary flow reserve. This tells us that this particular mouse has got a very nice coronary flow reserve. Another example is tack banding. And so you put a stenosis, create a stenosis surgically between the innominate and the left carotid. And this generates a huge pressure overload of the heart. So heart is seeing a huge pressure overload. And with this, what happens is the right carotid artery now becomes your major artery that takes up all that pressure. And so you can see the size difference between the innominate or the right carotid artery and the left carotid artery. Huge differences. And this reflects in the flow measurements we can bring. In the right carotid artery, you get huge pulsatile flows compared to the left carotid artery, which are dampened. And then at the stenosis, you can see the huge jet velocities. And using the approximate Bernoulli's equation, we can get a pressure gradient across this stenosis and define the severity of the stenosis. One of the interesting things that here we noticed is that if you look at the peak velocities, they are very high. But then when you calculate the mean of left and right carotid arteries are not very much different. And the reason we think, and that's probably the reason why they survive a few weeks. Otherwise, if their means were not different, if this mean was very, very low, that means there won't be any systemic circulation and the animal would die sooner than later. And that does happen if you have a very tight banding, of course. They would die sooner than later. But anyway, so you could see that we can get a nice characterization of the tack banding. So if you take the same group of mice with the tack banding, here you can see before the banding, you got a nice coronary flow reserve. You create the surgical band. One day after that, the coronary flow reserve starts going away. And by 21 days, it's totally compromised. And that's why if the mice live 21 days or maybe at the most to 28 days, after which they start dying. The last example I wanted to talk about is pulse wave velocity. And arterial stiffening is an important measurement, whether it's done in the aorta or sometimes in the resistance vessels, like in the arm in people, or in the leg. This methodology becomes useful, where you can measure from one location, get a signal, and time it with the ECG. This is if you have a single probe, and then you go to the second location, get this timing, and do pulse wave velocity. But this is non-simultaneous. That means this pulse is not the same as that pulse. However, if you have two probes simultaneously, you can put them in two locations, and if you can hold them stably, you can get aortic arch signal and an abdominal aortic signal, both going in the opposite directions. We can do this in the Doppler system. We trick the system into thinking that it is seeing the same signal by putting two connectors, by connecting both the signals, and then you have the timing. So using this timing, this is not influenced by any, if you're doing interventions, you could have transients as the drug wears away, but you're looking at the same pulse. That way you don't have to worry about the ECG timing changing and affecting this measurement here. So when you have simultaneous, you get the measurement in one shot. You don't have to depend on the ECG timing. So that's my last slide. And in summary, the Doppler system is non-invasive, so it allows for serial studies. As I mentioned, very small angles make the measurements more accurate, and you don't have to do the angle correction because a lot of times you cannot figure out what the angle is. And if you keep it low, then the errors are low. Short signal acquisition times. So within a few minutes, you can get your signals. It takes more time to set up the mouse than to get the signal. Can be measured at various locations, as you've seen in various arterial sites. It replaces invasive measurements. Key thing that we talked about. It is not echocardiography, just want to emphasize that again. And we can do systolic function, cardiac systolic, cardiac diastolic function, which is equivalent to LV relaxation, LV contractility, these two. Myocardial perfusion index, which is coronary flow reserve. We showed examples of TAC and how we can just look at cardiac function as well as coronary reserve in this model. And we talked about aortic stiffness, aortic or arterial stiffness. With that, I would like to acknowledge the funding sources, our technicians over the years that have helped us, our faculty collaborators, and other industry, as well as other collaborators from other institutes. With that, I thank you for your attention, and I'll be taking any questions you may have at this point.
Thank you, Dr. Reddy. And thank you for that wonderful presentation. As he mentioned, we will be taking these next 10 minutes to answer any questions you may have. A few questions have already been asked, so I will begin the Q&A, and I encourage those to continue to ask questions. The first question we got, Dr. Reddy, is can the negative dV dt max aortic deceleration be used as an index of LV, left ventricular relaxation?
That's an interesting question, but if you think about the dynamics of aortic, the valve closure, the LV relaxes, the relaxation starts to occur when the aortic valve is open. But as soon as the pressure in the LV drops below aortic pressure, you have a valve closure. So any relaxation part that you get, like the negative dV dt, is probably more characteristic of what's happening to the aortic flow and not what's happening inside the heart. So because the valve is closed, so I would refer to EA ratio as a more robust method to do that one, because now this waveform, aortic velocity waveform, is not seen. That's why we only look at the contractility part, because that's where both the valve is open and you have the left ventricular function or contractility pushing that flow out. Whereas the relaxation part, if you will, of the aortic signal, negative dV dt, it occurs only after the aortic valve closure.
Okay, thank you for that answer. Another question we got asked is, how is aortic flow related to cardiac output?
That's so one of the things that there's going to be a lot of confusion about, because people use flow and flow velocity interchangeably, but they're not the same. Flow is volume flow, and flow velocity is in centimeters per second. So if you think about flow itself, if it's flow, then it is directly related to cardiac output. If you measure it in cubic centimeters per second or per minute, that's the cardiac output. The aortic velocity, you need to take that and multiply it, take the velocity and multiply with the cross-sectional area, because it depends on the cross-sectional area. As you've seen in one of the figures, the aortic flow goes up when you have a catheter in place. So that's reducing the cross-sectional area. So in this case, to get the flow cardiac output, you have to measure the aortic diameter and use that to get cardiac output. But most cases, when as you've seen in the echo comparison, you can see that the aortic outflow is sometimes used as a crude index of cardiac output. So they both go in same direction with changes. But then you have to keep in mind that the aortic flow velocity can be influenced by aortic diameter. So you have to keep that in mind. Um, there are allometric equations that you can use, but then those are very generic. So you have to carefully look at your specific model of the mouse and see if it is the atherosclerosis mouse where you have stiffer arteries, they don't move as much. So what would be the diameter there? Would you compare that to a wild type mouse? So those aspects have to be, you have to be clear about those when you try to interpret that. But you can use aortic outflow as a rough index of cardiac.
Okay, thank you for that detailed response. We have another attendee who asks about the Doppler Flow Velocity software. They mentioned that they know that the Doppler Flow Velocity software does the analysis, but can the mean and peak acceleration values calculated by the program rather than exporting the envelope and calculating them?
Ah, okay, okay. Oh, so you perhaps talking about how we did this in this study.
Yes, I think so.
Um, in this study, we wanted to do it very carefully. So we just went ahead and used uh, the waveforms themselves and calculated the dPdt. The software I know allows for that, but you got to be extremely careful, especially when you're doing the peak accelerations, because peak acceleration measurement is a slope measurement. And if you don't place your marker properly, then there will be huge errors introduced into it. Um, Peak velocity, mean acceleration, which should use peak velocity and the timing, is less prone to that because it tolerates um, errors in where you place the peak marker. So it's less prone to the sensitivity. So what would be a way around? When you place the markers for the peak acceleration, make sure that you see the beat in an expanded mode. So each beat you have to kind of expand it. There is a scale, you can change the speed, if you will, on the screen as you're doing the analysis. That means use a 100 milliseconds or 200 millisecond window rather than using 1,000 millisecond window, because 1,000 millisecond window will have several beats and you will not be able to place your marker precisely on that acceleration part of the waveform. So yes, it can be done, but you got to be careful about especially peak acceleration. Mean acceleration, I think you can do that. We currently are working on somewhere. We will put this in our next, either it's, in our next paper, we will do these comparisons of by having 2 or 3 operators use the marker placement. They'll get the training and they'll place the markers and we'll compare with respect to the waveforms. And that way we know that what kind of accuracy you can get by using the software.
Okay. If anyone else has any future questions about the software analysis, please send it to us and we can answer them privately. Dr. Gamera, Dr. Reddy asks, and thank you for the presentation, but asks, if the accelerations in the aorta are deduced from blood flow velocities, does that suffice, bearing in mind that the aorta itself is an accelerating medium within the chest space?
That one is, I think that suffices because we are getting the acceleration. If you look at even when you compare the where the peak acceleration occurs in the left ventricular pressure waveform, you have the valve open, and so you're essentially seeing the velocity uh, accelerating at about the same point. So it's just comparing the two locations, if you will, of the condition is very similar. That means when the valve is open, it all behaves like one. The left ventricle and the ascending aorta or the aortic root, they all behave like one vessel at that point. So we think that it's the same at that point. It's a good representation.
All right,
It's
thank you.
not perfect, but it's a good representation at that point.
That makes complete sense. Another researcher or attendee asks, have you measured descending aortic velocity?
Yes, you can measure I specifically did not measure except to show that you can measure, but the key thing in trying to measure descending aortic velocity is to know your anatomy and see where you are placing the probe. And so I kind of use a little bit of like a marker. Okay, if I go a little bit further south, what happens to does the waveform still show up? And by manipulating the probe tip and the range, you can kind of figure out what's happening with the vessel. So if you're lined up with a vessel from, let's say, from the aortic arch, um, from the left arm of the mouse, and aim towards aortic arch, and you come further down, you will see descending aorta, but it will be in a very tight range. That means as soon as your range goes higher, the signal disappears. If it goes lower from a certain point, the signal disappears. But if you were to orient the same probe from the head of the mouse pointing downwards into the descending aorta, as you change your range, you will still see the descending aorta um, along that path, small path of the range. So that's how I figure out where the vessel is, what I'm measuring. I hope that answers your question.
Yes, thank you. And if everyone else is still curious about the different signals and measurements being acquired, feel free to ask. We have another question around different signals that you can get. Do you have any experience with the right ventricular function using this methodology?
No, we haven't used the right ventricular function. One of the problems we have with right ventricular function, uh, here we are not using image guidance. So we don't know if the pulmonary vessel actually crosses the aorta. And when you are aiming, or at least if you're thinking that you're aiming at pulmonary vessel, it's actually, it may be intersecting aortic, but you're intersecting aortic at an angle which is not ideal for aortic. So its peak appears diminished. So if you think back to the example where I showed in the echocardiography, where you get 58 or roughly, um, it's a diminished aortic, peak aortic velocity. There's, if we use our probe and try to aim towards pulmonary flow, the beam is perpendicular, or at least close to perpendicular to the aortic. So we don't know if we are capturing from the pulmonary or from the aortic, because the shape of the waveform is pretty much the same. And the timing, because they're pretty much coming out at the same, it's very difficult to separate the two. We know aortic outflow because the pulmonary peaks don't exceed or don't reach 100 centimeters per second. That's why manipulating with angle correction and all that it can be a caveat. That's why we don't use angle correction. And if you look at aortic outflow, it's anything above 70, 80 means that you're in the aorta. But then if you think you're getting pulmonary at that, high level, then that's not correct, because pulmonary pressure, the pressures on the right side are lower and your velocities are also much lower, but the shape of the waveform is the same. And that's why we have a hard time without image guidance trying to get that. So for those cases, we go back to echocardiogram.
Right. Okay. Well, thank you, Dr. Reddy. That does take us to the 1 hour mark. And to be respectful of everyone's time, we are going to wrap things up. As mentioned at the start of our webinar, we will be sure to answer any outstanding questions privately with anyone waiting for a response. And we will also publish a written transcript of all questions and answers from our Q&A session. We appreciate all the questions that have come in, and we will get to them at another time. I'd like to thank Dr. Reddy for his interesting and incredibly informative presentation. And thank you for taking an hour of your time today. Please feel free to reach out to us directly should you have any questions about the methodology used to acquire the data that Dr. Reddy presented today. And again, thank you for taking time out of your day to attending our session. We are hosting webinars in this month of March. If you are interested, please visit our website at syntica.com/upcoming webinars. Look forward to seeing you at another Syntic Instrumentation event. Have a great day, everyone.